We are live.
Good evening, good afternoon, and everyone. Uh, we're proud to bring to you the first Bone and Joint Infection Network Asian chapter, which is the initiative of the European Bone and Joint Infection Society. It's the first webinar of its kind. It's the first initiative of its kind. The initiative to start this network, this EBJIS Asia chapter, was taken up by the EBJIS Executive Committee under Dr. Ricardo Sosa, the president of EBJIS. So we are here with a multidisciplinary panel from across the European Bone and Joint Infection Society with infectious disease specialists, plastic surgeons, orthopedic surgeons. We have 4 speakers from Asia who are experts in their own in bone and joint infections. Like I said, this initiative was started by Dr. Ricardo Sosa along with the EC. He's a trauma surgeon. He's an orthopedic surgeon specializing in bone and joint infections. He heads the Porto Bone and Joint Infection Group. He's the current president of the EBJIS with multiple publications and interests in PJIs, FRIs. He has multiple awards to his credit. So before I go ahead and introduce the other faculty, Dr. Ricardo, if you could share your views on why EBJIS Asia and what's your vision forward?
Hi, Aditya. Thank you for your kind words. It's a real honor to be here right now as the president of the European Bone and Joint Infection Society to welcome everyone to this new initiative. So the European Bone and Joint Infection Society is a few years now under its belt, and it is mostly European based, of course, but in the last few years we have members joining us from all over the world, and especially a few members from Asia. You know that all of you are EBJIS members. And what EBJIS is about education on bone and joint infection and increasing awareness and developing multidisciplinary approach to it. The European Bone and Joint Infection Society is not an exclusively orthopedics society. It's not exclusively an infectious disease society. It's a society where we all come together, orthopedic surgeons, trauma surgeons, infectious disease specialists. Plastic surgery is also present, representing the plastic surgery in our world. And this seed of multidisciplinary approach is what EBJIS is about. And we think it is important to spread the word on the benefits of this team approach to the problems. And I think we can all learn with each other. Of course, European view is somewhat biased by our own problems, by our own reality. And we are always eager to learn from other geographies, other problems, other solutions for the same problems, innovative solutions. And that's why we imagine this branching out of EBJIS to different geographies, and in this case, Asia specifically with you guys. And I really would like to thank you. Thank you, Adita. Thank you, Dr. Liu. Thank you, Dr. Nilo, and Dr. Vikas for all your commitment to this project. And please, let's go ahead and start this one.
Thank you, Dr. Ricardo. So exactly, as he stressed, why we're here, because infections are here to stay. It's a challenge across the globe. A lot of problems that are similar, a lot of problems that are maybe region-specific or country-specific, but they're getting more and more challenging. And that's the reason why this initiative was started. We've shared a Google survey form where you can, if you're from the Asian region, interested in anything related to bone and joint infections, please do send in your details. There's a QR code which you can scan, take a screenshot of. The idea is to get collaborative, see what we can do together, conduct research in the future, have more webinars, and maybe a physical meeting somewhere down the line. So we have, like we said, a multidisciplinary panel. We have Dr. Alex Soriano, who joins us from Barcelona, Spain. He's a world-renowned infectious disease specialist, the immediate past president of the EBJIS. He's got multiple publications and well-known in the ID and clinical microbiology circles. He's an editorial member of the JBJI and has co-authored multiple international guidelines on antimicrobial prophylaxis. And I think the most challenging role that he's playing today, and the one he enjoys the most, is the local chair for the next EBJIS meeting at Barcelona in Spain in this September. So please do attend this meeting. We've all been attending them for many years now. And every year there's something new to learn from different topics, from different fields, which may not be completely related to orthopedic surgery. So please do join. These are the details of the website for the registration. We also have Dr. Willem from Belgium. He's a professor of surgery, the current Secretary General of the EBJIS. He's got multiple researches on implant-related infections. He's doing cutting-edge research in bacteriophages. He's the chair of the fracture-related infection consensus group. I think that was a landmark paper as far as FRIs are concerned. It was a group of clinicians who got together and laid down guidelines on how to diagnose FRIs. I think that's the biggest problem that we all face, is whether we are dealing with an infection at all or not. He's got multiple publications. So welcome, Dr. Willem, and it's great to have you here. We would love to have your inputs. To complete the entire team, we have a plastic surgeon, and he always, the few years that I've met him, he always has a smile on his face in spite of being surrounded by surgeons who create big defects and hand it to him. I think that's the first mark of saying that somebody really enjoys orthoplastic reconstructive work, and that's his area of expertise, trying to fill in the defects or the crimes committed by orthopedic surgeons. And welcome, Dr. Rick. It's great to have you here. Our panel from Asia has 4 surgeons from across the continent. We have Dr. Vikas Agashe, the senior most panelist here. He's been practicing orthopedic surgery for the last 4 decades, specializing in orthopedic infections, trauma, non-unions. Complex cases are his specialty. He's held multiple senior positions in AO Trauma India, in Indian Orthopedic Association, conducted various seminars and teaching sessions on infection within the country, spreading the word on how infection should be managed. He's been a national faculty at various courses. So welcome, Dr. Agashe. It's been a privilege to be working with you the last decade for me. We have Dr. Nilo Panna, who's a professor of orthopedics. He's a lead consultant for musculoskeletal infection service. He joins us from Manila, Philippines. He's a director. He's a leading part of the orthopedic department there. He's currently the president of the Philippine Hip and Knee Society, country delegate for the EBJIS, which highlights his keen interest in bone and joint infections. He also holds the position of the treasurer of the infection section of the Asia Pacific Orthopedic Association. So welcome, Dr. Nilo. We would love to hear from you and the challenges that you face. Last but not the least, we have Dr. Liu Yang, who's a professor from the Division of Microsurgery and Bone Infection from Chengdu, China. He specializes in trauma-related infections. He's a member of various committees and has multiple publications to his credit. We would love to hear the cases of intertrochanteric fracture infections, which are, I think, probably some of the most challenging cases that we see. And I complete the group here. I'm also an orthopedic surgeon specializing in infections, practicing in Mumbai, India. And with that, I would invite Dr. Agashe to start sharing his screen, and let's get on with the panel discussion.
Good evening, all. It's really a great pleasure to take part in this webinar. At the outset, I sincerely thank and congratulate European Bone and Joint Infection Society and the executive committee members, as well as Dr. Ricardo, Alex, Dr. William, Dr. Rick. I also thank Dr. Liu, Dr. Nilo, and Dr. Aditya for being here. And let us start with the first case. That was the most challenging case I've ever faced in last many years. And of course, I was supported by our multidisciplinary team of surgeons, microbiologists, ID consultants, plastic surgeons, histopathologists, and so many others. So I will be presenting a case of infected non-union femur after an open fracture with polymicrobial infection, with Enterococcus fecalis, multi-drug resistant Klebsiella, and carbapenem-resistant Pseudomonas aeruginosa, with a huge defect, almost 25 to 30 centimeters of defect after debridement. So this was a young lady presented on 15th February 2020. So these were the early COVID days. And she had very severe pain in the left thigh. You can see the external fixator is walking out of the femur, and she had purulent discharge from multiple sites. She had an open fracture about 7 months ago. There was a small puncture wound anteriorly. She was treated elsewhere with a primary intramedullary nailing. She developed early surgical site infection. She was on empirical antibiotics for some time, and at 3 months, the surgeon removed the nail and put an external fixator. Unfortunately, the infection persisted, and when she approached us, she was on multiple antibiotics for 4 months. Now, that's her clinical picture. You can see there was a sinus here, and according to the history, this was the area from where the bone had come out. Now, here you would observe that there is no extension of that wound, so probably only a local debridement was done. She was running high fever. There were another 2 discharging sinuses posteriorly. Most of the pin tracks were draining. Her inflammatory markers were high. And of course, she expected pain relief as early as possible. She was very, very uncomfortable. And of course, infection control and anatomical and functional restoration of lower limb. So we thought we must have a source control, have a meticulous debridement, kill microbes, obtain cover, address dead space, and add stability. So all in all, it did not appear to be a very, very challenging affair, something we do very often. Now, of course, the step 1 was a thorough debridement and external fixator removal. We probed the sinuses. All the sinuses were going up to the bone, 1 anterior and 2 posterior. And that was the incision we planned. We decided to excise all the previous scars, and the external fixator pin sites. Moment we opened, there was a large collection of pus at nail insertion. And the thigh exploration, there was an extremely foul-smelling discharge, and the bones were covered by thick infected membrane. Here you can see they were covered by thick infective membrane. So after we removed the membrane, you can see the bones were just necrotic, totally necrotic. There were multiple intracortical abscesses, and that was the proximal end. This was the distal end. Again, same thing, totally necrotic bone. And this was the area where interlocking screws were inserted. So the first thing is collecting multiple samples. And we generally have this chart pasted on our file so that our resident doesn't forget to fill forms properly, and we plan for sample containers and various tests. So this is what we found. We had a Klebsiella pneumoniae, which was resistant, Pseudomonas aeruginosa, which was carbapenem resistant, and Enterococcus faecalis. So here I would hold on for some time, and could I have opinions about the antibiotics and plan and treatment now? Dr. Menon, shall we have inputs from the panelist?
Yeah, I think Dr. Ricardo is,
Yeah, maybe I can jump in. The first thing I wanted to stress is what you already stressed in your initial presentation, is that the treatment of an open fracture, it includes a very good initial debridement, and that seems to be missing in this case, right? And then that's
right. Correct.
And you've stressed that, and I just want to highlight that because that's very important in my mind. The other thing is when you are faced with a suspicion of an acute infection, maybe you need to start being more aggressive in that. And I think maybe William can comment on that and how to address an acute infection, and then we'll get up to this chronic stage that is very, very, very challenging. William, do you want to comment something on acute infections?
No, I think you're right. I think initially you need to be aggressive, but we have to understand that it's still a fracture in the earlier weeks and months, meaning that where we initially thought of really performing an oncological resection, in some cases it is necessary, but in some cases we are now more judges, try to keep as much bone as possible when the bone is still alive and bleeding, of course. But I agree, Ricardo, in the early stages, the Brightman in the specific early fracture situations and open fractures is very important.
While the bone is still alive, maybe you can deal with it not in this aggressive way that you need to do it now, that you needed to do it now because the bone was dead. And maybe in the acute stage, that's the main message. There are other ways to deal with infected fractures, right?
Yeah.
Right.
Dr. Alex, yeah, sorry, somebody was saying something.
No, yeah, I'm going to pass it to Alex now because that's his kingdom now.
So you've got a polymicrobial infection, highly resistant one. Do you see this very often at your area, in your area? And two, would you be happy with orthopedic surgeons trying to preserve live or vascular infected bones, or would you be better off as an ID specialist if we end up removing all the infected bone, whether vascular or not? So that's always a give and take between us and the ID specialists as to what's the best way.
Well, this is one part where definitely Europeans needs to learn quite a lot from you, yeah, because this epidemiology in bone and joint infections is not so common. I mean, multi-drug resistant Pseudomonas as the one that you presented here, where all the beta-lactams are resistant with a very high MICs, and where probably the only option is a colistin with the problems associated with colistin, and it's even resistant to amikazine, for example. Yeah, so the opportunities to use a beta-lactam or to use a combination of two drugs are quite short and mainly limited to colistin. Yeah, at least for Pseudomonas. For the Klebsiella, we have more options because it is susceptible to meropenem still, and the Enterococcus faecalis is susceptible to penicillin. Yeah. So it's evident that when we deal with so complex microbiology, to remove all the dead material is absolutely essential. Yeah. Otherwise, it would be very, very difficult. And so from my perspective, of course, as much as the infected bone needs removed is much better, because to prolong the antibiotic therapy with colistin is associated with nephrotoxicity almost 100% of the time. Yeah? So we don't have so much alternatives here. And to be so aggressive in surgery, it's quite even more important than normally. Yeah, because here the antibiotic options are few and toxic.
Okay.
From the Asian group, any inputs?
Yeah. Dr. Nilo, Dr. Liu, you have any inputs?
I'm sure you must be also
Yeah.
coming across resistant bugs like this.
Sorry, I really have no added comments at the moment. Yeah.
Right. Okay. Sorry.
Yeah. Yeah.
Sorry. I think you were saying something.
Yeah, I was just asking Dr. Liu if he's facing similar scenarios in China. Are the pathogens as resistant as we are seeing here in India?
Yes, it's also the same. We also have met some many kind of this complication or maybe complex the infection of osteomyelitis. So this antibiotic is hard to choose. Sometimes we have to some antibiotic administration policies. So we have to choose ask the infection disease expert to help us to choose antibiotics.
All right.
Right. Yeah, thank you. So I'll just proceed. The ID specialist initiated ampicillin and substandard avibactam. She said that she would need for about 6 weeks or 8 weeks. Unfortunately, the fever persisted. Pain did reduce to some extent, but only about from 9/10 to VAS score came down to just 5. ESR, CRP were still high. And then we opened again. Again, there was foul-smelling discharge. This was the third time. This was till then, we were probably a little conservative, as you had said, that maybe we can keep live infected bone. And that is what we were trying to do. But we realized that with this high resistance, there's no point in even trying to salvage a bone which is live but infected. So we went really radical this time. And then you can see that's the distal fragment and that's a proximal fragment. This is after third debridement, she was very comfortable. We just wanted to confirm that the wound was okay. And this is the fourth debridement. That's a proximal fragment and that's a small distal fragment. So the gap was almost 25 to 30 centimeters. We had not kept the other limb draped, so we really could not make out the limb length discrepancy, but the defect was significant. And so we put Stimulan or with Vanco and gentamicin, and here you can see the huge defect here. So we felt that we created an uninfected envelope. The question is whether it remains infected or not, only time can prove. Yes. Now, this was the first week of March. COVID wave was rising very rapidly, and we had instructions to vacate the hospital. The question is, how do you manage somebody with such a huge defect? But funnily, her pain decreased significantly. Just 1 week, we could start mobilizing her with a brace. And this is her at the time of discharge. She went home to her village and she sent this photograph at 8 months. She was just about going to touching, but of course, we had COVID days, and then she presented at 20 months requesting reconstruction. There was no pain, no fever, huge defect. The wound had healed very well. Inflammatory markers were absolutely normal. And now is the question, what do we do? Should we amputate? Should we reconstruct? Or should we replace the femur? Now, I'll open it for discussion.
Yeah. I think it's an open house for opinions.
Can I jump in?
Yeah.
Yes.
So I think neither you nor her, you want to go for amputation. So you fought so hard for this leg. And I'm guessing she doesn't want to go for amputation. I'm guessing you also don't want to go for amputation. I mean, you were able to apparently to cure that terrible infection. And now you have apparently uninfected massive bone defect. So if we take amputation aside, because that's always an option, but it could have been an option earlier and you didn't go for it. That's when I would ask my reconstruction team, and right now this is William and Rick, because I always remember for reconstruction, you can do it either bone transport, you can do a free fibula, but it seems too big for it, and maybe some induced membrane techniques. Rick, what do you feel about free fibula transfer for the femur? What's your opinion on that?
Yeah, so usually the free fibula used to be a good option because we did not have a lot of experience with distraction osteogenesis. But it takes an awful long time until the fibula for such a lengthy defect integrates and can bear load. So in the tibia cases, we stepped away from this and we rather do bone transport techniques. You know, you can, in this specific case, you probably could think about taking a proximal bit of the bone, but sometimes you can also do a double bone transport, but we don't go for long bone defects with a free fibula anymore because of the integration time is just too long. The patient, in addition, cannot weight bear, which is differently usually if you use, for example, an external fixator device system, such as a circular device. So I'd rather go for a distraction osteogenesis in this case.
Right.
Willem, what's your thought on that? Distraction, this entire femur. Do you have a bone to start with?
Agree with Rick is that we have experience with the femur and the free fibula. The problem is weight bearing time. You need double plate for stability. It can work, but it's not ideal. So for the lower extremity and the free fibula, we're not really a fan. We go for the free fibula for the upper extremity. And for large humerus defects, for example, it works great. Distraction works perfect. The problem here is a little bit, the segment is small. You don't really have a lot to pull, you know, so I would need to surgically plan it on the x-ray. It will be the limit. So I'm also interested to see what the outcome was here. Other options are masculae. Masculae are an option, but I'm not really a fan of femur and tibia. We did a lot of them. And you have to discuss with the patient that the outcome of success is like 50%. So it can work, but in 50% of the cases in such a large defect in the lower extremity, you won't have success. A tumor prosthesis, I would not see it really as an option at this moment in time with such severe infection. I would maybe be a little bit hesitant at this moment in time. I would try and reconstruct it.
Right.
Yeah.
I'm an arthroplasty guy, and I try to avoid tumor prosthesis in these young patients whenever possible. It's always better to replace with bone if it is possible to do some kind of reconstructive rather than replacement, because she's 25, right? She's a very young lady.
Yes, 25. Very young, very young.
Yes, I'm also very curious to learn what you did in this terrible case.
Is there any other opinion? Okay, then I'll go ahead. So we will have a detailed discussion with patient and family. So first and foremost, they said salvage the limb at all cost. Avoid, rather attempt reconstruction as far as possible. She said, I don't mind walking with a stick all my life, but I would definitely not like to have an amputation or a prosthesis. Our social conditions are a little different as compared to Europeans, and we really don't accept amputations so easily. So the points in favor are we have a clean wound, there's no evidence of infection, but we have a large defect. Distal fragment is very small, and even the proximal fragment is extremely small. We did consider segment transport. We thought we may not be able to transport almost 30 centimeters here. I mean, that would be, and it would take a very long time. Chances of complication would be very high. So finally, what we thought was step one, of course, we decided to open and take multiple cultures, check all the fragments, samples were negative. So we decided that we'll go and reconstruct. So our thinking was doing segment transport would be extremely challenging, and transporting 30 centimeters would be out of question. So we thought we would do, stretch the limit of live fibula. Apparently 20 or 25 centimeters is considered to be maximum, but we thought, well, let's see if we can do this. And there was practically no bone in the lateral condyle. So we thought we'll put a allograft in the lateral condyle, put a angle blade floor and lateral distal floor, cement spacer, and after 6 weeks or 8 weeks, we'll do a microvascular transfer. So here you can see that's the femoral head allograft, which we punched into this defect of lateral condyle. This is where it went. So we got some hold in the distal fragment. And then we used the cardiac bypass tube to prepare the cement spacer. Here you can see that's the variable angle femoral plate, and that's post-op. That's the spacer which went in like this. And then we planned for a vascular fibula at 6 weeks. We thought the fibula would be about 27 centimeters, and we have almost 37 centimeters of fibula. So we were generally very, very happy. Unfortunately, when we explored, we realized that there was practically no bore here up to the most distal screw. And we were forced to put in 30 centimeters of microfibula. And distally, you can see we have practically no fibula there, just a small tip of lateral malleolus. Really extremely scared, but I mean, there was no other option but to do this. In spite of that, we had about an inch of shortening. So shortening anything more than that was out of question. So this is what we did. That's in OT. And 6 weeks down the line, we had this problem. Remembered the paper by Dr. William on FRI, and she presented with significant swelling, redness, and obviously it was early FRI. She was on thinners. The plastic surgeon was not very keen on our doing anything, but I mean, we had no choice. It took, of course, 2 more weeks to bite the bullet. By then, you can see the infection was significant. So this is when we opened at 8 weeks. The plate was covered with the infective granulation tissue. Again, we debrided well. We opened all the incisions. You can see we had opened the anterior incision also, but we took tremendous care because there was anastomosis anteriorly. Now, this time, it turned out to be MSSA. So obviously, it was not a recurrence of old infection. It was a classic surgical site infection after a closed fracture treatment. So she was given sulfazoline and oral rifampicin and fluoxetinool for a long time. And here you can see these are the previous culture reports, and that's the MSSA this time. This is at 3 and 7 weeks, no signs of infection. At 8 months, we realized that there was a distinct defect here. So we decided to put in iliac crest graft there. So we punched in the iliac crest graft here. This is 14 months post fibula and 6 months post tricortical graft. She's consolidating both the ends, but we have still kept her with a stick. We're not very keen on asking her to go full weight bearing. That's the appearance and knee range. That is 4 years after presentation. Very, very comfortable patient. And we were all very happy. That's patient and the relatives, patient and her knee movement. But if you want to spoil your good results, you must have a good follow-up. When she came in 2 years and 4 months after free fibula, for a routine function, very, very, very comfortable, extremely comfortable, very happy. And then we noticed this. We noticed that there was a stress fracture at the distal part of fibula, not the distal end of fibula, almost about an inch, more than an inch, proximal to the distal end. And here you can see that's the stress fracture, and that's the level of fracture. So the fibula is right there. That's the end of fibula, and that's the fracture we have. Now what should we do? First and foremost, what else we could have done, or what could have been done differently in the terminology, and What should we do now?
Yeah, Alex, first of all, I think this is a very, very good case, and that clearly illustrates what I said initially about being more aggressive in acute infections. So you recognize an acute infection early, and you acted earlier than the initial approach than elsewhere. So, and you managed to suppress this infection or to treat this infection. Alex, do you have any comments on that rifampin flucloxacin suppressively? Did I understand correctly? Did you put on rifampin suppressively, or just took out the rifampin after a few weeks? What happened exactly?
We continued it for 4 months.
Hmm. Well,
Continued rifampicin for 4 months.
yeah. Well, maybe just a comment, because the surgery was a huge one, yeah, and something that it's always important in terms of antibiotic prophylaxis during surgery, particularly when it takes so long. I mean, so long means more than 4 hours. Probably this surgery takes, I don't know how long it was, but probably more than 4 hours. It's very important and critical to perform an accurate antimicrobial prophylaxis. If we are using a first-generation cephalosporin, for example, cefacillin, the half-life is about 2 hours. So it means that at least after 3-4 hours, we have to repeat the antibiotic prophylaxis. And this is very critical. And I would say always that it's much better to repeat every 3 hours even, although probably or theoretically it should be every 4, because beta-lactams are quite safe drugs. I mean, we can administer without any problem. And when I see these so long surgeries, in the end infected by an Staph aureus, methicillin susceptible Staph aureus, I think that sometimes it's important to be sure that during all the surgery, the patient had good antibiotic enough levels in order to prevent. This is just a comment, yeah, because sometimes we forget to repeat the antibiotic prophylaxis during surgery.
Right.
And repetitively a problem, yeah, associated with infection. Just a
You're
comment.
absolutely right. That is exactly what we routinely do. Anytime the surgery extends beyond 3.5, 4 hours, we repeat the prophylactic antibody. Yes.
Yeah,
It was done here as well.
It is very, very important. And in terms of the antibiotic treatment, it's true that the beta-lactam, I mean, I would agree with at least 4 months for this patient with a combination of rifampin. Maybe the difference here is that probably we would use a fluoroquinolone instead of a beta-lactam. I cannot see whether the quinolones were susceptible in this case. I see that it was susceptible to several things. But not, for example, clindamycin, but it was susceptible to beta-lactams. But I don't know for fluoroquinolones. Maybe we quinolone instead of a beta-lactam, because it's I mean, comfortable oral therapy. If it was the case, susceptible, of course, yeah. But maybe the difference. But 4 months, I think that if the patient was in a good way, I think it's good enough.
Rick,
Any other opinion? Yeah.
Rick, did you ever do such a big fibula flap? Like, this is a very long flap, no? This is
Yes.
impressive.
So, I mean, I congratulate the surgeons that they did the fibula, and obviously the fibula is working, so the bone is actively perfused. If I got it right, it was augmented with a non-vascularized iliac crest, and we are very, very hesitant in using non-vascularized bone if there is a vascularized option in a situation where you've had a polymicrobial infection and possibly microsequesters all around, although you might not detect them, because you just give, as you see in this case, Staph aureus, a chance to colonize a non-vascularized bone graft instead of having a vascularized bone graft. So I was wondering, I know it's difficult to find plastic surgeons all over the world to engage in these kind of surgeries, even more difficult to have plastic surgeons repetitively engage in these surgeries. But if you have the chance, just as a general remark, you can also use the vascular iliac crest in a vascularized way, given you know that the vessels are all right and that it's technically feasible. It may have been a better outcome.
Possible. The only thing is the spacing between FRI, that means free fibula, and the non-vascularized graft was almost 8 months. We did it after 8 months, not together. But yes, I think that is a very, very important suggestion. I think we'll keep it in mind next time. Thank you.
And Willem, I heard you talk about double plating for fibular graft. Do you think that would be an option initially to avoid the stress fracture, or maybe this is an option now to treat that fracture? What are your thoughts?
So, like Rick said, the issue a little bit with the free fibula, again, we did similar cases like here for the femur. The issue is a little bit weight bearing, takes a very long time, where you often see the fibula really integrating and becoming a humerus, for example. This doesn't really happen for the femur. And so that's the reason why if we perform free fibula specifically for the lower extremity, we learn that we often go for double plating because they tend to break after 18 months or even earlier. And even for the upper extremity, for the humerus, for example, we have a low threshold also when possible to go for double plating to give the fibula a little bit more stability. And with the change in that protocol for us, I would say never see deep breaking anymore. But breaking of the fibula itself, it's not often really an issue specifically. I mean, also for the tibia and the humerus, it's important to explain to the patient what they need to do, but often giving them a period where they don't weight bear, for example, it doesn't often need to be that you need to perform another surgery. It depends, of course, if your plate breaks or if there's instability or any other issue that you don't have an integration, that's something else. Rick?
I just wanted to add exactly the same experience as you, Jan Willem. When you have a fibula and you want it to become more load-bearing, I mean, why would the fibula corticalis become hypertrophic? And it is usually when you start weight-bearing that when the fibula breaks, but the hardware can still take it, it is the fracture of the fibula which then starts to hypertrophy and make the connecting zones of the bone better. And there is just a technical addition to free fibulas, which may help in this case. You can raise the fibula, but also raise the periosteum flap with the fibula and make the periosteum flap larger than your fibula. So when you, I mean, this was a very long fibula. This will be difficult, I fully understand. But if you do, let's say, a regular fibula, you can raise the periosteum with the fibula, but extend the periosteum proximally and distally maybe 1 or 2 centimeters. So you have a viable periosteum flap with your fibula flap, and you can wrap around the periosteum from the fibula around the fracture zone or the docking zone. And this periosteum is highly bone induction, is a highly strong bone induction motor. So this is just a technical issue, how to maybe improve the docking zone with the free fibulas.
Right. I think that's a very important point, very useful hint. In fact, it might add to the stability also to some extent. Thanks for that. Any inputs from Dr. Nilu and Dr. Liu?
All I can say is that I'm thankful that we really haven't had any experience with these types of difficult cases. So congratulations. Well done.
Dr. Liu, any opinion?
It's a very complex cases. Congratulations. I think maybe also the weight bearing of microfibula is a very important question, but I have no experience for them this kind of lung defect using microfibula. Thank you for your sharing these cases.
Right. So a couple of things that we thought we could have done differently. One is if you see the fibula is on the extremely lateral side. The fibula is not centralized. And it happened when we put in a plate. The plate, I think, could have been tilted a bit from proximal side. We could have used a Cotrivire technique to check that we have a central. What happened is it is going into the little varus. So if we had tilted the plate a bit, probably our fibula could have been in the center. And maybe it could have hypertrophied better, possibly. Second, I was just wondering whether we could have done Kapana's technique. But I think we are fortunate that we didn't do it, because with FRI, then it would have been extremely difficult to manage fracture-related infection after Kapana's. Now, obviously, we are thinking of various possibilities, leaving alone brace, electrical stimulation, teriparatide, denosumab. But what we are seriously thinking is two things. One is, as mentioned by William, that one could put a graft as well as a double plate. And this is publication from our colleague, Dr. Sanjay Agarwala, who has used denosumab as a repurposing agent for recalcitrant bone healing. So these are the two things we are seriously considering. I think we would probably go in for another plate on the medial side and a graft. So just to summarize, our thinking about infected non-union is first and foremost assess location of infected tissues, debribe and access source control, identify or if not possible, guess microbe, kill them, prevent reinfection and superadded infection, achieve good soft tissue cover, achieve good host status of comorbidities and habits. All this would help us to achieve a closed, uninfected soft tissue envelope and maintain it. Somewhere during that time, we have to achieve skeletal continuity in acceptable alignment, and stability would always help. In case we cannot achieve skeletal continuity, then of course we have to achieve continuity by implants or compromise, have pseudoarthrosis, or finally have an amputation. Most important thing is having a multidisciplinary team. Without that, managing such challenging cases is impossible. Thank you, friends.
Thank you. Thank you, Dr. Rashmi. That probably was one of the most challenging cases that we've seen. We've had a lot of discussions on it. We'll get back to this case at the end of it with questions. We'll go on to Dr. Liu for his presentation on infections following intertrochanteric fractures. Dr. Liu, welcome, and we're looking forward to your presentation. And we get back to the delegate questions at the end of the cases. I think we'll have a panel discussion through this and get back at the end. Could you share your screen? Yeah, we can see it.
Dr. Liu, you're muted.
Okay, can you hear me now?
Yes, we can. Yeah.
Okay. My name is Liu Yang. I'm from China. We will talk about the intramedullary landing FRI for the intertrochanteric fracture. During the last 10 years, more than 10 years, we have met more than 18 cases of the FRI of intramedullary landing for the intertrochanteric fracture. We have seen various presentation on the X-ray, such as bone resorption and around the nailing, and cutout of the blading, and resorption of the around the blade resorption. Sorry, and we also can another virus kind of presentation on the X-ray, and there's a on the right side is a patient with removal of implant and infection. So this 18 cases is has many virus presentation, and just like this is non-union this patient have infection, and the breakage of the plate, the screw is breakage, and then another patient is have the bone resorption and infection of the hip joint, and the implant also pulled out from the intermediary canal at the right side of the sliding. And this is also a very complex infection of also including the PJI. It's a very complex infection. We just only finished the prepare to revision these cases, but this patient general condition is poor, so we have to give her some more support therapy, and then we will go to the revision of these cases. And we also perform the sinus sonograph of the X-ray. We can see the sonograph on the CT and the MRI. We can also clear finding the border of the soft tissue and soft tissue border, infection border. And we also have met many cases of the local presentation with struct and the bridge and the red swelling insertion. And this is a kind of a complex local presentation. The right side of the tree also the corner or on our this sliding. We also have many kind of different presentation of the intraoperative images, such as the blade infection and the cup infection. And the left side two picture is a patient with infection of fungal, and now this is a cast of this sliding. This patient is a male patient with 56 years old, and he was fractured after falling. And when this patient to my outpatient service, it's also after 42 months after index fracture surgery. And this patient is also suffered drainage for more than 3 years. The patient have no smoking history, but this patient have type 2 diabetes. The laboratory of result on the right side is also abnormal. And this is local presentation of the patient to my outpatient service. This is more than 3 drainage, sinus tract drainage. It's a very complex infection and around the hip joint. And the X-ray presentation on this slide is also we can see the distal locking screw have the bone of resorption on the lateral side. On the CT scan, we can see the distal of the femur have also osteolysis, and on the lateral side of the proximal have the defect. And the nuclear SPE CT scan, we can see the nuclear enrichment on the middle of the femur. It's the same local of the distal locking screw. And this is also nuclear enrichment. On this picture, we can see the enrichment, the nuclear enrichment on the distal locking screw area. So we diagnose this patient is a little FI of the intramedullary nailing for the intertrochanteric fracture. But with consideration, this patient have fracture malunion, but his proximal femur is stable. So we first step is to remove the implant and debridement, and implant the bone cement rod and bed. This is the intraoperative image. We can see the patient have drainage from the posterior of the side. And this is also, we can see the infection around the blade. And we remove the blade, we can see the blade have some infection tissue. And we also can see on the left side picture, we can see the infection around the caps. We remove the cap, also can see the infected tissue around the cap. And all this pulse also around the distal screw, locking screw, we can see on the left side picture, we can see the pulse drainage mixed with the blood. And the cover of the distal locking screw also have infection. And we use the bone cement to make a bone cement rod to insert the intramedullary canal. And the right side is implant we remove. And we also use culture site, including one swab and 2 bottle culture bottles, blood culture bottles. One is aerobic, another is anaerobic. The culture result is Klebsiella pneumonia. So we use antibiotic treatment, epinia and celastatin. And for 3 weeks, and later we we use additional antibiotic is clindamycin, and 3 weeks later we perform the second surgery to remove the cement bed. And this we can see. Okay, we can see this is a the second local presentation, the second surgery. So we have to do the debridement and remove the cement to throw out the drainage, and we also use the vacuum assisted therapy. This is X-ray after second surgery. We can see we remove the cement bed, but remains retention the cement rod. This is a local presentation after second surgery. So we plan this third surgery to closure this incision. This is X-ray after third surgery. We enclosure the incision and retention the cement rod. After therapy, that the local presentation and soft tissue is recovery, and no sinus tract and no drainage. After 5 months after first surgery, 5 months after surgery, we plan to the patient soft tissue condition is okay, and the laboratory result is also normal. So we plan to use iliac bone graft for the femur neck defect and bone cement augment for the great trochanteric. This is the fourth surgery. This is the MRI. We can see also have some soft tissue reaction on the MRI of the site. And after surgery, we can see the bone cement. We use the iliac crest bone graft for the femoral neck, and the bone cement for the greater trochanteric to support and augment. But unfortunately, for maybe 5 months and 10 months after first surgery, the patient for drainage to the outpatient service. You can see this. A lot of drainage. So we have to perform the next surgery. We want to perform the debridement and secondary closure. This is before the surgery of the fifth surgery. We can see on the CT scan, we can see the abscess on the side of the with the arrow point to this soft tissue abscess. This is abscess also can see on the MRI. After surgery, it performs the debridement and the soft tissue condition is okay. And this is X-ray on the fifth surgery, after surgery. Now, in this junior, we follow up this patient. This soft tissue is recovery and no drainage for more than 6 months. So this patient is just feel satisfaction with this result. But the question is also including about this. When we remove the implant from the intermediary canal, we can see some patient have the pseudomembranous of the intermediary canal of the proximal femur. So the next for our question is at this. Which size, three question is which size is correct to debridement of the intermediary canal? Maybe 2 or 5 millimeter larger than the needle. And the question 2 is which instrument is appropriate for debridement of intermediary canal, reamer or curette or another instrument. And the question 3 is how long should we remove the cement rod of the intermediary canal? Because we know the time in the tibia infection is 6 weeks. 6 weeks, but this is also same on the femoral neck femoral infection. This is my sliding end. Welcome everybody to Chengdu. It's a very fabulous city and with a hot pot and panda. Thank you, everybody. I will go back to the question slide. Okay.
Thank you, Dr. Liu. I think intertrochanteric fracture is probably one of the most challenging as far as management is concerned. So it's open to the panel for comments on this case. How would you do it differently? How would you tackle it now at this stage? Dr. Ricardo, Dr.
Maybe
Lim.
start.
Yeah.
We can maybe start with the questions, Ricardo. So there's no evidence specifically on the debridement itself of the canal. What we know is that it needs to be thorough. Just using a curette is often not enough. So using a reamer is, I think, today's standard of care. 2 or 4 millimeters. It depends a little bit on the patient, on the cortex. I would go at least 2 millimeters, and depending on the chronicity, maybe even to 4 or even higher, but this really is patient dependent. The main question that we often get is, do we need, for example, a RIA device? The RIA is the irrigation aspirator system. Looking at outcome, there are 1 or 2 studies stating that between the standard reamer and the RIA, there's no difference. The only reason that we often use the RIA system is that we can take cultures in a very standard fashion. And we published in the Journal of Orthopaedic Research that it even will lead to, or will lead the physician to find other important, I would say, pathogens that you were not able to find with standard curettes with less contamination. So in our hands, we would often use the RIA for that reason. Very, very important. Question 3 is the time you leave the cement rod in. The problem is there is no standard of care in time. You know, it isn't. I often tell the residents and the regional surgeons here, I would like to have it out at 6 to 8 weeks, because the problem is a little bit that after that, often you lose the patient. They go to another outpatient clinic, for example, or the general physician for a few weeks. And if you lose them then for a few months, it's very difficult to get it out, or you will not be able to get it out anymore. It integrates a little bit. And I have a lot of cases from one of our retired surgeons who left them in. And then specifically after 6 months or 8 months, it integrates and you can't get it out anymore. So for me, standard of care is 6 weeks. In certain cases, I would go a little bit longer, but rather not. And to be honest, our regimes are going to a shorter time frame, so a shorter interval. So you have the acute infection, you clean it out, you wait till the soft tissues are good for 3 weeks, look with your plastic surgeons, when can we plan it, if it's necessary, as soon as possible, maybe even single stage. So they leave the cement rod only in, for example, for 2, 3, maximum 4 weeks, just to have good soft tissue coverage and a short time of high dose antibiotics with the PMMA. But the problem with the PMMA is if you leave it also after 6 and 8 weeks, you go under MIC and then you get resistant strains, has been published as well.
Professor William, the question is, I have read some video from the AOS talking the instructional course lecture talking about the cement rod in tibia. The recommendation, the 6 weeks is okay. So this is also same on the female. And then another question is, in China, we also have the RIE, remote irrigating aspiration. But the question is the nailing of the femur, the intertrochanteric fracture, the nailings, the diameter of the nailing is 10 millimeter. But the largest the reamer of the common usually is 40 millimeter. But due to the price is very high of the RIA system is very expensive in China, we can't, the patient cannot afford this instrument, so we have to use the common reamer, but the limited or the largest diameter of the common reamer is 40 millimeters. So we have sometimes have some difficulty to eliminate the infection of the intermediary canal. So it's a question how to. I know this have no standard recommendation for the diameter of the reamer during this kind of femur intermediary canal infection, but sometimes some male patient have a large diameter of the intermediary canal. So we sometimes have also use curity and the reamer to resolve this problem. It's very difficult.
Yeah, I fully agree. And to be honest, the price is a problem here as well. It's very, very expensive. With an RIA 2 now you can go up higher. We have also standard reamers that go up to 16, 17. So I think that's really important that you can try with the company you work with to have reamers that go higher than 14, specifically for the femur. 6 weeks for the intramedullary rod. Also for the femur is fine. I would try to take that as a maximum and not go over. And finally, the curette is fine. If you have a long curette, it will work. It is a bit more work. You have the longer hip curettes, you know, that works also perfectly fine. It's just sometimes difficult if you have in the chronic late onset cases, the very hard, strong bone, to get that out of the femur canal. And, that's the only reason that I like, if when possible, to go for a reamer, it's just more aggressive.
Thank you.
Let me make a question to both of you. When you use a standard reamer and not use RIA, does it make a difference to do a distal window in the distal part of the femur to let the dirt come out, let's say? And the other question is around cement rods. Do you use it only when you need stability, and use resorbable bone carriers when you don't need stability, or what are the cases where you use a cement rod, or you try to avoid using that cement inside the bone?
Yeah, good question, Ricardo. So the blowout hole, as the Americans would teach us, I remember, I would say 10, 15 years ago, is that, in every case when you debride the canal, you need a blowout hole. The problem is if you treat hundreds of them, then by the end of the day, you have a few of the blowout holes being infected by themselves, which is not really an issue. So I use the blowout hole when I don't use the RIA. But what I do now is that when I use a standard reamer, and I know I will, as a second step, use the RIA because I always combine them, then I'm not using the blowout hole in a standard fashion anymore. But I will use a blowout hole when I can only use a standard reamer. In some cases it is, which is fine. I think it's important indeed to get, the dirt out, as you say it, and get full irrigation, which is sometimes a little bit difficult in a vacuum system like your intramedullary canal is. The tibia nail or the femur nail, it's not only for stability. In the femur, it's even difficult with the standard nail, the PMMA nail, to get stability. You would need to coat a standard implant. We use the humeral nail, for example, which is 7 or 6 in diameter, roll it in PMMA, and then use 2 locking screws to get some stability, because by itself, the PMMA nail doesn't give stability. It's really used for local treatment, and I think more and more data comes out that we need local, maybe even more or as much as our systemic treatment. So for me, the idea of using the cement rod, there's not really an issue if there's stability or if there isn't stability. If there's too much instability, that's really a problem in cases of infection. Then it's sometimes even difficult to use just the PMMA nail by itself. Then you indeed need something like a standard implant that you coat in PMMA temporarily.
And
Exactly.
in my hospital, we don't have the resorption, the cement, just like bone support. So this is a very big question, because this kind of just this kind of cement, just like the bone support, is expensive and not approved by the FDA in China. So we can't use this kind of the resorption cement. Another question is the distal dirty debris cleaning. We usually create a window and the distal locking screw, and we use drainage to suction the debridement debris out from the distal intramedullary canal. But in fact, it's very hard to remove all the debris from using this kind of technique. Maybe we can use more irrigation volume, can try our best to eliminate this kind of debridement debris. So it's a very difficult question, because we can't use RI because it's too expensive.
Yeah. All right. Any other comments from the panel? Dr. Alex, do you want to get in onto the Klebsiella here? Or?
Well, definitely there is a bias to gram negatives in Asia, definitely, that it's more common, in particularly Klebsiella, no? That it's normally producing many different beta-lactamases, and it's difficult to treat. Here it's more common, maybe gram positives, although gram negatives are increasing, but definitely also difficult to manage. I don't know how often do you have new antibiotics like ceftazidime-avibactam. I see that for the other one, you had the opportunity to use ceftazidime-avibactam, and now we have new beta-lactams that are coming in the market. So probably will be helpful for managing this complex infections.
Yeah. We are seeing as many gram negatives as we're seeing gram positives, and probably that's an Asian problem. It's a region-specific issue. If there are no more comments, Dr. Agashi, you wanted to say something?
No, I'm absolutely fine with this.
All right. Okay, so thank you, Dr. Liu. I think it was a challenging
Wonderful
case. Intertrochanterics are extremely challenging, especially if they're not stable. So with that, Dr. Nilopan, I would invite you to take over the screen, and we'll have a PGI in this mix of FRIs.
All right. Okay. So thank you, Adi, and good evening again good evening for us. Good morning, good afternoon to wherever you are in the world now. So I'll be presenting a case of a partial two-stage exchange for a periprosthetic joint infection after total hip arthroplasty. So presenting a 71-year-old male with a chief complaint of the draining sinus over the right hip. So a bit of history: 1964, had an unrecalled hip surgery on the right hip, and in 2008 had a total hip arthroplasty for a femoral neck fracture. So patient was doing well until October 2019, where symptoms of fever, swelling of the right hip presented, and patient was treated by a physician with antibiotics for a month, and apparently the symptoms actually resolved. So he was doing well until January of 2020. So 3 months later, there was recurrence of the draining sinus over the right hip, over the previous surgical site of the total hip. And as we all know, March of 2020, there was the lockdowns happened worldwide because of the pandemic. So patient was then lost to follow-up, and I was only able, patient sought consult with me after 6 months, mid of 2020, and still with the draining sinus present over the right hip. So after further discussions with the patient and the relatives, we planned a month later for arthrotomy, debridement, and removal of the total hip prosthesis and application of a antibiotic cement hip spacer. So these were the clinical pictures of the draining sinus upon admission. It was not actively draining at that time. And these were the preoperative x-rays during admission. So we can see here a long stem, fully coated cement stem, and a large cup with several broken K-wires and a cerclage wire which was used to fix over the metaphyseal area of the proximal femur. So for the perioperative course, did a standard posterolateral approach to the right hip, was able to remove the acetabular cup using an explant device without any difficulty, and proceeded then to do an extended trochanteric osteotomy of the proximal femur to be able to try to take out the long, fully porous-coated cemented stem. And unfortunately, the only tools I had available with me was using giggly wires to be able to try to remove the stem from the medial cortex after my extended trochanteric osteotomy. But in spite of that, I noticed an impending fracture distally my trochanteric osteotomy. At this point, I was already afraid of doing the fracture to propagate. So what went wrong was that, well, there was an impending fracture of the femoral shaft, and I failed to remove the well-fixed femoral stem with my limited instruments that I had during that time. So what did I do? So I abandoned removal of the stem and fixed back my trochanteric osteotomy with multiple circlage wires, and decided to just wrap the exposed proximal end of the stem with antibiotic cement. So these were my initial post-operative X-rays. So I was able to wrap around the femoral neck with bone cement, and I was able to reduce the hip, and I used multiple circlage wires to put back my trochanteric osteotomy. So these have been reported several times. So 2019, Krasinski et al., selective component retainment in treatment of chronic BJIS, partial two-stage exchange of infected total hips. So several reports already of technique being done, and with fair to good results reported. So my post-operative course now was cultures luckily turned out to be well, Staph aureus, and since the Philippines is endemic for tuberculous infections, whenever we get cases of PJIs, we always have to screen for tuberculous infection. So although my TB PCR turned out to be negative, unfortunately I was not able to retrieve my histopath results. So we placed the patient on 2 weeks of IV antibiotics and shifted to oral antibiotics for around 8 weeks. And luckily, we monitored our infection markers and inflammatory markers, and there was a decreasing trend for our ESR and CRP. And the wound healed well with no recurrence of the draining sinus. So I guess that we got lucky with this case, since we were also dealing with a quite easy to treat bug. And since inflammatory markers were already normal at this point, after 3 months, I was able now to go back in and do my second stage revision for the cup. I was able to put in, unfortunately, we did not have any available larger cup. So I had to put in the same size cup that same as the one that I removed, since there was no larger cup at that time. We have to keep in mind this was still the pandemic, and stocks of implants were quite scarce at that time. And the post-operative course back at this time was also unremarkable. There was already beginning healing of my trochanteric osteotomy. Unfortunately, after 6 months of post-second stage revision, this was the well, I was only able to follow up the patient via telemedicine, since this was still the height of the pandemic, and although this was the latter part, this was already early part of 2021. You have to keep in mind that the Philippines did not really. We were one of the last to get the COVID vaccine, so everyone's still so afraid to go out, and telemedicine was still the way to go back then. So unfortunately, I was sent these X-rays via email, and quite alarming. You can see that seems the cup has moved. But when I asked how the patient was doing, he was very happy with his hip. He was able to sit down. He was quite functional, able to stand. Anyway, he was already an elderly man, and all he wanted to do was sit down and watch television, his favorite television program, the whole day. So I guess at the end of the day, I could say that what is important is if your patient is happy, whatever the result is, I guess we can be happy with that. Okay, so takeaway from this would be we can consider a partial two-stage revision for total hip arthroplasty for very selected patients. It's not really a treatment for all. But if you have limited resources, like our situation, and you're dealing with a very long polyporous coated stem, probably you might want to limit your morbidities and more problems, probably you would like to consider is doing a simple, wrapping up the exposed metal with bone cement, and you might also get lucky just like me. Anyway, that ends my short presentation, and yeah, like to hear some feedback from the panel.
Right. Fantastic. Thank you, Dr. Nilo. I think what you highlighted is every region has its own issues, and especially COVID posed a lot of restrictions as far as availability of medicine, surgical implants are concerned. And coming out of these challenging situations, not having everything at your disposal is probably when you come up with ingenious ideas, something that will make do for that time being. And what your last slide shows that probably we treat the patient and not the X-ray. The patient's happy. You would want to go in as a surgeon and do something there, but that's at the cost of the patient being happy at this stage. And would you really want to be aggressive? So you get the panel on this, Dr. Ricardo. I understand the situation in Portugal in some areas may be similar to this, if as far as socioeconomic restrictions are concerned, or would the government pay for everything? Because that does dictate a lot of the surgical or medical options that the surgeons in a lot of countries or in a lot of regions in Asia would face.
I have two comments on this case. The first one is, I think, one educational comment is, I think around 2019, was it, Nilo, that you describe what it seems like a late acute infection? So the patient has done well for 11 years, and then he's got a swollen hip that went away with antibiotics. I think, well, there is a mischance there for a curative their approach at that time point, and I just wanted to stress that out. If you're facing a late acute infection, you have a very good chance of curing it with a debridement and antibiotics and implant retention. And moving on to the solution is, of course, this is one conversation that I always have with my patients. These long stems, ingrowth, these are very difficult to get out. And also very complex acetabular reconstructions that are also very difficult to take out. And so the principle is that you need to remove all the implants to cure the infections. But sometimes the better goal is not to cure the infection, but rather treat the patient. And I agree with your comment that sometimes you need to dial down on your aggressiveness and surgery just to treat the patient, but these are selected cases, and you've mentioned that on your talk. And so this is a very selective approach. In my hand, this is not like a common thing, like partial revisions. But whenever I'm faced with that challenge, then I always have a conversation with Alex, or someone like Alex. Is after this, would we do a suppressive treatment from the get-go? Just do a suppressive treatment and assume the infection is not cured, but rather we're going to live with it, Alex?
Yeah, I think this was my comment that I wanted to address also. Yeah, maybe there is a point, as Ricardo mentioned, whether my patient has a late acute infection, where maybe the option to be success by giving maybe 3 months of antibiotic treatment and acute debridement, etc. Maybe we are having a good success, although it's true that late acute infections, even though have a lower success rate than early acute postoperative infections. This is true, but I agree that at this point, maybe you are succeed. But if my patient has a chronic infection, and finally I decide to do a partial replacement, that it's something that we also discuss in my team, and we recently reviewed the data that you presented. Yeah. Is this a real option, particularly for an old patients? Not because of we maybe don't have the constraints in Spain, no, in terms of economics, but sometimes to remove these stems, it's very aggressive for the patient, and sometimes we discuss about that. Yeah. And then maybe for a chronic infection, I would agree with the surgeon if he considers that it's the best way, but then probably I would prefer to maintain suppressive therapy, particularly in old population, maybe with cotrimoxazole or with a tetracycline, minocycline, for example, that is not so expensive. And then we can maintain with a relatively low dose of one of these antibiotics, and then to maintain for a prolonged period of time. Because if my patient in the end, 1 year later, fails, then it's problematic, yeah? Because then the patient is 1 year older and more complex to go back and to go to the surgery again. Now it's even more difficult. So probably this is the only point yet that maybe I will prefer, if my patient has a chronic infection, to maintain suppressive therapy with all the discussions behind, yeah, because the literature, it's not so high on this point, but it's quite interesting approach, yeah.
Yeah, thank you for those comments. I agree that I guess we missed that window of opportunity to actually treat an acute hematogenous PJI during the October 2019 in the history. Unfortunately, it's still common practice in our part of the world wherein antibiotics are being used to treat PJIs, which we all know that success rates would be close to nothing with just antibiotics. But unfortunately, since you have to keep in mind that here in our country, all the patients shoulder medical expenses. So whenever you tell them that you'll need surgery, it's a big no-no for them. And they will always ask if couldn't we just give medicine for that, for that problem? And sometimes that's what the physician would actually decide to do, since they don't want to lose the patient. They just want to make them happy. So, yeah. But I guess that's the one of the initiatives of our group right now, right, is to properly educate, to spread the spread the word around, and if I may use the term, spread the gospel about infection treatment, right? So hopefully with this initiative, we'll be able to reach more colleagues and probably really spread education to all our colleagues.
Sure.
We are also facing exactly similar situation, similar challenges.
Patients choose to go to clinicians who would give them antibiotics rather than advise surgery. So that's when patients pay out of pocket, they choose probably the easiest option when things are not bad, and when things get really bad, then they have no option but to get operated. So that's unfortunately the reality. But I mean, we're here to discuss both ideal and reality. So if there are no more comments, I think we'll move on to the last case. We were already short on time, so I'll quickly run through this case, get in the panelists in between. So this was a multidisciplinary management of a case with multiple things happening at the same time. Again, we work as a team, Dr. Agashi and myself, and we're just the face here. There's a whole group of specialists managing all of these cases who get in at an appropriate time. So this was a 47-year-old diabetic, a very common picture in India, poorly controlled diabetic, excessive swelling and pain in the left leg. You can see it's almost double the size of the right. Had fever going on for a few days. HbA1c was skyrocketing. It was more than 10. Counts were high. CRP was 192. X-rays seemed pretty normal, and that's what you see in acute presentations. So differentials, most of these patients would be diagnosed either as a cellulitis or a necrotizing fasciitis or an abscess. They would generally get an ultrasound. Here, the ultrasound sonologist was very experienced, and they, other than the subcutaneous and the muscular abscesses along the tibialis anterior, they also detected a subperiosteal abscess. Now, if this subperiosteal abscess would not have been picked up, a lot of times these patients would undergo surgery for a soft tissue infection without any further investigation, especially being a diabetic. Soft tissue infections are the commonest. But the patient came to us to the emergency department. As a protocol, we got an MRI with diffusion, with contrast studies, with a diffusion scan, and these were the coronal sequences. Just get the laser out. And so there were cortical breaks at 4 centimeters and 12 centimeters from the joint line, massive subcutaneous abscess, subperiosteal. and about a 20 centimeter involvement of the medullary canal of the tibia. That was acutely osteomyelitic. You can see the same on the T2 image as well. You can see this, these are the cortical breaks. This is the T1 image, 20 centimeters involvement. What was interesting or worrying as well at the same time was the subcutaneous abscesses was so diffuse that almost half of the circumference of the skin had limited vascularity, and that's where the diffusion scan comes in. So there was soft tissue abscesses, there was loss of vascularity. You can see that black patch on the front. So that showed that the vascularity there was compromised. There was frank osteomyelitis. So there were multiple things that we were dealing with, and we realized that we may end up doing much more than what you would generally do for an acute osteomyelitis. So here we were faced, and in addition, there was septic knee with synovial effusion, with synovial thickening. So there was a septic arthritis, there was osteomyelitis, multiple abscesses, extensive along the whole leg, and the soft tissue looked very, very dicey, very much like a necrotizing fasciitis would look like. So there are a lot of things happening here. There was a plan to drain, and I leave it out to the panel here for the first part of the discussion as to what would be the plan here. Would you prefer doing multiple small windows or drill holes in the cortex for an osteomyelitis, or would anyone go in for a reaming? So these are the surgical questions that are posed to us. So I would want to open this out right now to the panel as to what are the surgical options that we're looking at, what are the discussions that we can have with the patient.
I think you need to be very aggressive here. Probably we would go for reaming as well, but probably also for cortical windows, also to see what the bone quality is. And then at that time, decide in what extent you need to move on during surgery. But for sure, making a cortical window, maybe even a large cortical window, and then in combination with reaming of the canal, because through that cortical window, sometimes it can be difficult to clean out the whole canal like a tooth.
Yeah,
not sure
absolutely.
I think I would go for a similar approach regarding the osteomyelitis. I will also add probably I think an knee arthroscopy to the synovectomy, or doesn't seem like it's very old, so I think you can get around with the arthroscopy of the knee, cortical window for sure, and debride the intramedullary part of the tibia. And as far as there are no major soft tissue abscesses, there are only minor, multiple but minor soft tissue abscesses, right? Or
no, they're pretty major, pretty major. So there are big abscesses extending a significant amount on the anteromedial and anterolateral aspect, and involving the tibialis anterior muscle. So it was extensive.
So just open approach of those, and use that approach to the cortical windows. And
yeah. So that was the plan, that we go in. These were the markings. So what we thought was the synovitis could have been reactive. So that was one doubt that we had, especially with such significant infection. You do find reactive synovitis and effusion. There was tenderness, so we decided first to debride the tibia. We incised, and the minute we incised, this is what we found. There's massive amount of pus pouring out through the subcutaneous right under the skin. So that's not tissue that we can leave in or debride and expect it to heal or have any kind of vascularity. So we went half a centimeter at a time, kept on excising infected tissue till, and you can see the top left image again, frankly infected. As we kept on excising, we realized that the abscesses were right up to the skin, and that's exactly how necrotizing fasciitis present. So this is a patient who had soft tissue abscesses along with the necrotizing, and that's the amount of soft tissue that had to be excised till we had vascular healthy margins. A significant amount of tibialis anterior muscle also had to be removed. This was the cortical break which we had seen on the MRI, and that's where the imaging comes in. We speak to the imaging consultants. mark out the cortical window. That's what we had planned in this patient, as to what would be the length of the window we would need to scrape out the canal. Reaming was an option, but again, the approach would have been slightly more proximal. Yes, we were going to open the knee joint if infected, but by and large, what we've seen is we've been able to access the medullary canal, especially the epimetaphyseal zone. That's the area where there was a significant infection, and that's somewhere a reamer doesn't really do justice. So this is what we made a long oval window, significant amount of granulation tissue pus seen in the medullary canal, scraped out everything, and you can see that window gives us, you can use an ENT burr or any kind of orthopedic burr, smoothen out the edges, make those windows, and use curettes along the entire medullary canal from the epimetaphysis down to the distal diaphysis, and we could scrape out everything. That's at the end of the leg. And then what we realized was as soon as we finished this part, there was pus trickling down from the knee. So we did an open arthrotomy since we were already there. It was frankly infected. The gutters along the patella tendon, medial and lateral gutters had to be cleaned out, synovectomy. And then came the investigations part. So here I would want to get Dr. Alex in. So we do deal with more gram-negative bacterial infections, but globally, should we have a common list of investigations that we do, maybe say include tuberculosis as well as bacterial tests, or do you generally test only for bacterial infections and then keep the other tests as a standby or an extra sample? So should there be region-specific investigations that surgeons should order, or should we have a global list of investigations that should apply across the world? Dr. Alex, your take on this.
You mean to do a different test like molecular testing, for example?
Yes, whether molecular testing, or should you look for fungi, TB at the same time, or should it be region specific for testing for the samples?
Yeah. Well, of course, in regions where TB it can be a possibility, as our colleague from Philippines mentioned before, it's necessary to look at. But to be honest, this now we will see which is the pathogen, yeah. But apparently, this is a case that probably, I don't know, looking at the past history of the patient, it seems that that is a chronic osteomyelitis that has an acute, an acute phase now, and probably it's an intramedullary abscess that opens through the wound and through the bone and contaminates all the surrounding soft tissue. Yeah, and in my experience, the majority of cases are due to Staph aureus. Yeah. Is probably the most important pathogen here. So, well, for sure, I will do the classical microbiological test. Probably also molecular testing could be, if in the end the standard cultures are negative, and to look for tuberculosis or even fungi. Well, normally. It could be particularly tuberculosis and fungi in this patient. Well, I don't know in your region or whether the patient has any trauma or penetrating trauma that could advise on the possibility of fungi. Otherwise, this patient, if I'm not wrong, was not immune suppressed. Yeah, I mean, it was a non-immune suppressed patient.
Perfect. Dr. Rick, you wanted to say something?
Yes, thank you. I'm not sure, Aditya, if I got it right. Did you call this a necrotizing fasciitis?
So it presented with subdermal abscesses right from the skin up to the deep fascia. It was right throughout that sheath.
Yes. Because I'm not sure, maybe I'm not 100% sure about the definition of necrotizing fasciitis, but usually if I see patients which do have a necrotizing fasciitis, and if I miss that diagnosis, usually within 24 hours, they are dead. So I think it is a cellulitis with fasciitis, but I'm not sure if it was necrotizing, because otherwise it would have been a different clinical course, and I mean, you go there, you see this typical dishwatery liquid coming off your fascia, and the fascia is falling apart, and you have in your ground staining your rods. But I'm not so sure if this were really a necrotizing fasciitis or rather a cellulitis, over time necrotizing your soft tissues, because then the approach would be a little bit more different. But as said, I'm not the IED specialist, so I leave this up to Alex and your colleagues. But just with the necrotizing fasciitis, I'm not 100% sure.
But I think it's an osteomyelitis that is open to the soft tissue, no?
Yes, yes.
I mean, it has an intramedullary abscess that probably finds a way out and then contaminate the surrounding tissues and this big abscess. If I understand well the case, yeah?
Absolutely. So it was probably something which started as an osteomyelitis, broke through, came out, formed soft tissue abscesses. But what we generally don't find is intradermal abscesses like we found in this patient. So the soft tissue excision that we did was very much like you would do in a necrotizing. And the MRI and the diffusion picture also was similar to what you would find in a necrotizing. I'm not saying this falls under a classical necrotizing, but you would really not have so much soft tissue or skin excision in an osteomyelitis with abscesses. We generally don't end up with that. It's bony clearance, yes. Deeper abscesses, yes, but not so much of skin excision. I mean, that's something that we rarely encounter. So, and the diffusion, which was missing in that entire area of skin, which was surprising.
Yes, thank you. Just in general, sorry.
Yeah. Go ahead.
I was just going to say the general comment, in accessing the tibia surfaces in any option, being it FRI or being it soft tissue trauma with open fracture, etc. I was wondering, usually we try to avoid to cut over the anteromedial plane of the tibia, because there is where the skin is most delicate, and you really try not to touch that area. But as you explained very much in detail, it had to be done. But this is just a general advice, the surface of the anteromedial tibia should remain untouched if somehow possible, because even if you have a 2 by 2 centimeter soft tissue defect, you will have to have a soft tissue reconstruction, which then, depending on the localization and more distal, it becomes rather quickly an indication for free flap, which is hardly usually available.
Absolutely. So that's the discussion we had with the radiologist. What would be the ideal approach? And he said anteromedial is where you'll find the maximum infection. So we hate that incision. We either go posteromedial or we go anterolateral, but our hands were tied here. Yeah, Ricardo, you were saying something. Okay. So I'll just go ahead. Yeah, so this was a picture that shared by Dr. Agashe. What we've realized over time is we see a variety of infections and we don't try and guess the bug, because we've been surprised more often than not about we were expecting or suspecting ABC, or rather the infectious disease team, which gets involved with the patient at the time of admission or in the outpatient clinic much before the surgery. So this is the host of tests that we do for every patient, for every sample. And we started using BioFire as well now. It's only because we are seeing so many infections. And this is what we've realized since 2020, that we've set up a protocol, we've done a prospective study, we've stopped guessing as far as surgeons what we're dealing with, or ask for limited tests, because we're seeing as many gram negatives with gram positives. We're seeing fungi as well. And it's only in 4 of these 19 cases that fungi were actually suspected as the pathogen. The other 15 were surprising results from deep tissue, and they were not even contaminants. We're seeing hosts of non-tubercular mycobacteria, which get referred to us, which have not been picked up for many, many months or years. And they're basically lack of infection control practices. But these are the reasons why, I mean, especially in our region, we are trying to test for as much as possible, as quickly as possible. And that's helped us identify 90% of our pathogens. And with the resistance patterns that we're seeing, with carbapenem resistance being almost 10% or 20% of the gram negatives, it becomes paramount for us to not just find the pathogen, but know the resistance as well. And that's where BioFire came in this case. Within 3 hours, we knew we're dealing with a Klebsiella. Again, I think it's a favorite bug in the Asian region. It's not staph, which you would normally expect. in somebody who had no trauma, no open injury. We got a gram-negative infection. Same thing was corroborated on the standard cultures as well. 6 out of 8 samples grew Klebsiella. It was pan-susceptible. And Dr. Alex, quickly a comment from you about it could possibly have been a hypervirulent or hypermucous. This is the input I got from the ID guys. We don't really have that test to find out whether it could have been this. But a Klebsiella in a patient with fulminant infection, pan-sensitive, could have been a specific variety of this bug. Your take or experience on this pathogen?
Well, there are descriptions from Asia mainly that a specific ST11, and then this is a sequential type 11 of Klebsiella pneumoniae is particularly virulent. Yeah. And it's able to produce this kind of so severe infections, so aggressive, quite acute, infecting everywhere. And of course, beyond that, of course, the microbiologist can see that in the plate because it's producing quite a lot of mucus, viscose colonies. But apparently also there is a specific sequential type that is inducing this or that is related with this high virulence. Yeah. But again, it's something quite common in Asia where you know more than us for sure.
So possibly it could have been this. Like I said, it wasn't really, we didn't have the test for it. The colonies looked like that grossly, but the treatment was, we used negative pressure therapy at this stage. Orthoplastic one stage would have been pretty challenging, one, because of the availability of a plastic surgeon then and there. Two, whether we could actually get source control in one surgery is again challenging. So this is the antibiotic regime. If you want to comment on this, we were shifted to oral ciprofloxacin after the first couple of weeks. I think it was more of a broad spectrum first initial 2 weeks because of the presentation. And the challenges were whether he would need a bone graft because of the long window, maybe an external fixator. What about the soft tissue cover? So your comment on the antibiotics, and then we'll take Dr. Rick's comment on what cover can we do now.
Yeah, well, in terms of antibiotics, I think, I mean, I agree. I don't know if 2 weeks of broad spectrum would be necessary or not. Probably I would reduce the spectrum earlier if finally the cultures show only Klebsiella. And maybe I did not see the antibiogram, but if a cephalosporin is susceptible, high-dose cephalosporin, for example, cefotaxime or ceftriaxone, maybe cefotaxime would be better. And associated with ciprofloxacin, I totally agree that I would do dual therapy in this case. And finally, quinolones, particularly when susceptible, and ciprofloxacin it was susceptible, I think it's important to combine into antiquinolone here. I would do the same. Maybe just I do more shorten the period of piptasa, and I would switch to a cefotaxime, for example, plus ciprofloxacin.
Sorry, my network was a little weak there. Rick, you want to comment on the... Hello?
Yes.
Yeah.
So
that's the defect there.
Yes. So the knee without an extensor apparatus is useless. Because
so the extensor apparatus is intact here. Sorry. This is an anteromedial side. So the patella tendon is intact. The patella quadriceps, everything is intact.
Okay. Well, if it is intact, you know, the proximal third of the tibia you can reconstruct with the medial gastroc flap. But as you already have delicate soft tissues, which were usually when you use negative pressure wound therapy, you know, you can get the edema out of the tissue, but the tissue itself becomes harder and less pliable and less extensible. So now you're dealing here with a soft tissue defect in the proximal 2/3 of your lower leg and the middle third of your lower leg. Very, very hard to reconstruct with local flaps. Sometimes you can use the soleus or a hemisoleus flap, but this is extremely challenging. And I mean, if you had the means I would really go for a free flap reconstruction. But as said, I'm not sure if I understood you right, that the extensor apparatus is still intact.
Yes, it's intact.
Okay.
So what is your opinion about negative pressure therapy? How often do you use, and in which cases would you use?
So my
Case
policy,
like this, would you or not?
no, I never use negative pressure wound therapy in open bones. Never. Because it triggers an ideal environment for resistancy development, because you've got a piece of foam which is 30 degrees warm, it's full of liquid, you've got the antibiotics running, but they are not in your foam, you've got negative pressure, so you are basically using a bioreactor for antimicrobial resistancy development. So the advantage of negative pressure wound therapy is you can get less edema in your wounds, which is ideal if bones are not involved. You never use, or you should never use it in exposed bones. Sometimes the only exception is when we have 3rd-degree open lower leg fractures. We use it as a very short bridging procedure until final reconstruction. But in general, I would never put it on a bone.
So how early would you go in for a flap in this patient after the primary debridement?
So I would try to go as early as possible, because I know that there's been a kind of a change, that you debride first debridement, second debridement, third debridement, but the old school, let's say, would state that you debride until you find no bacteria anymore in your wound. But what you will then find is pretty soon you will find often a fungus in your wound, because you've killed all your microbiome in your wound. And our policy is you reconstruct as early as possible, not only to cover, but I would rather call it reconstruct your soft tissues, because it is only through your reconstructed tissues that you can have nourishment and antibiotics delivery to the area where you need it most, and which is your exposed bone, because through the bone there's always the top layer which will not get the antibiotics, and it is only through your soft tissues where you can have antibiotic delivery onto the spot where you need it most. So the answer is as soon as possible.
Fantastic. Perfect. So this is what free flap was discussed, but again, socioeconomics is an issue. If it fails, then it's 100% failure and the patient's paying out of pocket. So what they said is the plastic team said that we try a local flap, we'll see where we head with it. We've not burnt a bridge as far as the free flap is concerned. So they did a medial gastrocnemius. We put in calcium sulfate beads in the medullary canal. Then they did a transposition for the middle and lower third, and then a graft over that. And so the other thing orthopedically was whether we use a fixator to stabilize this. What we've generally found is if the window is oval, less than 30%, by and large, they do consolidate along the margins, and no bone grafting or fixation is required in most of them. So this was a 6 weeks follow-up. The flap had healed. Antibiotics were, I think, stopped at this stage. And unfortunately, what happens, we've seen this in some of the patients, that after a flap, they need to be in a long knee brace or some immobilizer. They go in an external rotation and they develop a neuropraxic common peroneal palsy. Now, that's something that we've seen once in a while with some patients, especially the ones who had to be immobilized. I don't know if that's a problem that you face, or with flaps or limbs that need to be immobilized. Rick, have you seen any such complications?
So the peroneal palsy, I see that often in patients who receive a lateral gastroc flap, even though you operate meticulously, but you can wrap around your lateral gastroc around your fibula, and always whenever you do that, you will be in the area of your common peroneal nerve, and this one is really susceptible to just a little bit of pressure, and takes a long time to recover. But from having these patients, just from bed rest patients, I've only seen common peroneal nerve palsies when they have external rotation because they have an intubation or so, and there's not enough care to pad the lateral knee sufficiently. And then when they lay hours and hours on their proximal fibula, I see often common peroneal lesions, which will then take a year or two to recover, but they will recover, yes.
Yes, exactly. So that's what we've been seeing, that in spite of padding, some of them, when they go back home, they remove that padding and then they don't realize that it's going in an external rotation. And he's improving. It's taking time, but there's gradual improvement with the palsy. This is now an 8 months follow-up. He's mobilizing independently, and that's where we are. We're actually about 12, 13 months since the surgery. Again, follow-up is a little bit of a challenge in our region. When they're fine, they don't really want to come back to the hospital for a checkup and get evaluated. So the take-homes from this case were, a lot of times these cases would get diagnosed as a soft tissue infection, but MRI is probably a gold standard in every infection now, as long as the patient's stable. We plan out the cases with the radiologist as far as the approach, the extent of infection. Region-specific panel for tests are required. We do all of them because we're facing a lot of variety of pathogens and resistance patterns, and combination of good reconstruction. I think I'll change that word from cover to reconstruction, along with local and systemic antibiotics can help us get away with a good outcome in most of these cases. So thank you, and it's open to the panel for discussion.
Well, this is another impressive case, and it just goes to highlight the importance of multidisciplinary work that you guys did, and it's critical in all these complex patients.
So I think we've overshot our time by about half an hour. There were a couple of questions from the delegates that we could take. Can we take a couple of questions from the and then wrap it up? So the first question was to all the panelists that should there be, in case of limited availability of a plastic surgeon, how challenging or easy is it for an orthopedic surgeon to do extensive debridement? Should he or she actually undertake it in their center, where there may be limited access to a reconstructive surgeon, or immediately transfer that patient where you're suspecting that you may have to do much more than a standard incision? Because the plastic surgeons, I mean, reconstructive surgeons availability may not be as easily accessible in most, even in Mumbai. I mean, forget a town in India. So,
well, maybe I can jump in because I'm also have a very difficult access to plastic surgeons. So what we did in our department is that some of us microsurgeons guys, the hand surgeon guys, they do some of the free flaps, and of course some of the local flaps you should learn to do it if you're a bone and joint infection surgeon. Some gastroc flaps, they are very easy and very helpful around the knee, and you should learn to do it yourself. But I think the correct question to that answer depends on how sick is the patient. Does he require immediate or urgent surgery, or does he have a chronic situation that is prone to center transfer?
Dr. Agashe, Dr. Nilo, Liu.
Yeah. So we also face these problems quite often. I would again say that if the patient is too toxic and debridement has to be done, then it has to be a proper debridement, irrespective of whether you have plastic surgeons or not. Your debridement has to be perfect. In case patient is stable, has been going on for quite some time, then you can transfer. If you feel that it is acute, then you do the debridement and then transfer. But I don't think you should compromise on debridement because you do not have access to a plastic surgeon.
Correct.
I totally agree with that, Dr. Agashi. We usually teach our trainees, whenever you do a debridement, it has to be a fearless debridement. You don't really think of the reconstructive part first. It's your main goal is to really remove the infection. So it really has to have the fearless attitude whenever you do your debridements, and just worry about the reconstruction at a later time, or let someone else, worry about it.
Yeah, absolutely. Dr. Liu, do you have the same challenges at your workplace as far as reconstruction is concerned, or can you hear me? I think there's some. Anyway, I'll move on to the second question. The second question again goes to all the panelists. Another challenge that most clinicians face is antibiotic therapy once they get discharged, once they go home. That's so whether IV or oral, how do you manage that at your institute? Dr. Alex, are there any nursing staff that are trained for it, or surgeons, or how do you do it?
Yeah, well, there is a lot of consideration that maybe IB is much better than oral, but in the end, if you are selecting antibiotics that have a good oral bioavailability, oral it could be as good as intravenous therapy. This is particularly true with quinolones. Quinolones had a very high oral bioavailability, and there are other drugs with a good oral availability, for example, cotrimoxazole, but also linezolid, that it's something that you know well, although the toxicity should be, should be careful with that. And when we have one of these drugs, normally what we do is 10 days, maybe 1 week, 2 weeks. It depends on the patient, on the microorganism. But then as soon as possible, we switch to oral therapy. In order to avoid problems related with IB lines that are common, and particularly because the data supports, for example, OVIVA trial that it was published in New England some years ago, demonstrating that when you switch to oral therapy, the outcomes are as good as 6 weeks of IB therapy when you switch to, after 2 weeks IB. Yeah, so I think that the data supports oral therapy by selecting those drugs with high oral bioavailability.
Great. So I think we'll wrap up our session now because we've run out of time. It's been a fantastic session to start off this new venture. So I thank Dr. Nilopana, Dr. Liu Yang, Dr. Agashe for fantastic, challenging cases. It's easy to show a success, but very, very difficult to show probably your worst nightmare come true. So thank all of you for showing these cases and set the ball rolling. Of course, a big thanks to Dr. Ricardo, Dr. Rick, Dr. Alex, Dr. Willem, who had to log out, for your support and your initiative. And I hand over to Dr. Ricardo to close this meeting with his final thoughts.
Well, I cannot thank you enough for organizing this. I hope it has been a fruitful session for those attending. This is what the EBJIS spirit is about, this multidisciplinary engagement and learning from each other. And I just wish you all the best for this initiative. And you just, everyone out there listening, just you're welcome to come and join us and join the Asia network. And that's it from my part. Thank you very much for your initiative.
Thank you. Thank you, everyone.
Thank you very much. Thank you. Bye-bye, everybody.
Thank you. Nice to
Thank
meet
you.
Thanks a lot, everybody.
Bye.
Bye-bye. Yeah. Bye-bye.
Rishi, you can stop the live streaming now.